Hello there, everybody. I am Dr. André Theron, all the way from George in South Africa, and I would love to present this identification of risk for the development of chronic post-surgical pain, a phenotype approach. That's a mouthful, but hopefully you'll stick with me to the end and hope we'll learn something together. First of all, I have no conflicts of interest. With this specific talk, I do develop and present ultrasound guided and perineural catheter workshops for Bayut, South Africa, but that's not a problem for today. When we look at chronic pain, chronic post-surgical pain, we have to start looking at areas where we can improve our patient management. And the phenotypic approach, which has been developed and is currently being studied more extensively by our colleagues in Harvard, they have developed wonderful programs and they are busy testing this. So please watch that space. First of all, let's quantify the problem. Chronic pain is an epidemic affecting more than 1.5 billion people worldwide. In the US alone, 100 million adults struggle with some form of chronic pain. This is more than diabetes, cancer, and heart disease combined. Physicians who treat pain have noted marked variability in pain responses, and I have seen this where you treat patients with the same arsenal of medications on trial and error basis, and by the time they get to a pain specialist or for definitive pain management, they don't want to try another treatment, they don't want another block, they don't want to do anything. They are sick and tired. So getting this right in the beginning will help us later on. The problem is, efforts to quantify the incidence of chronic post-surgical pain ranges widely. And this is mostly because of the research where the definitions we're measuring are different. And we'll go into more detail with the research later on. Then patients with chronic post-surgical pain are at risk for developing opiate addiction. And again, prevention is key. We don't want these patients to get to that place. Now we have some new insights on pain phenotyping. Now, a phenotype refers to a set of observable characteristics of an individual from their interaction with the genome, with the environment. Patients experience pain differently, which may explain the wide variation observed in chronic post-surgical pain in the literature. Also, recent literature now, especially from our colleagues from Harvard, have shed some light on the identification of a pain phenotype perioperatively, which can assist us with prevention of chronic post-surgical pain. We as anesthesiologists are in a perfect spot to help identify these patients at risk who are going for elective surgery and then implementing the correct pain management strategy to help these patients according to their pain phenotype and to decrease their risk of chronic post-surgical pain. There are lots of factors involved. There are some biological factors, which we'll go into detail with all of these groups a little bit later. But there's biological factors, the genetics, the age, the sex of the patients that have a role in the pain phenotype. There are some social factors, whether it be isolation, cultural influences, positive support at home, that also have an effect on your pain phenotype. Then some psychological factors, anxiety, depression, stress, sleep disturbance, and catastrophizing. And then lastly, what we do, the anesthetics, analgesics, and the surgery and the surgical extent also play a role on this specific patient. Now, the biological factors influencing the post-surgical pain. First of all, there's a variability of neurotransmitters and enzymes and inflammatory modulators or mediators that can heighten the nociceptive signaling and sensitization. Peripheral and central inflammation significantly shape pain processing, and then a younger age and a female sex are associated with greater postoperative pain and a higher post-surgical pain risk. Lifestyle factors, physical activity, nutrition, gut microbiome, all influence the inflammation and pain responses. Then lastly, genetic prediction for chronic post-surgical pain is currently very limited due to the involvement of so many mediators and gene-environment interactions. It's very difficult to quantify this. So what we also see is that heredity of chronic post-surgical pain, 38% of patients have this. So reflecting that the environment is a more substantial influence and the other causes are more substantial than genetics alone. So the differences in immune regulation, COMT, and opioid receptor genes are not predictors and they're not definitive. It's difficult to test, it's costly to test, and they are not good predictors. So the phenotype measurement remains the most practical approach to managing these patients. Then there's biophysical factors. Now, quantitative sensory testing helps us assess the general pain sensitivity and provides insight into the individual differences in nociceptive processing. So this is one test that we can do, which is fairly simple. Then higher baseline nociceptive sensitivities are measured perioperatively, and these are consistently linked to increased risk of developing chronic post-surgical pain. So pain amplification measures, such as the temporal summation of pain, so TSP, that's another factor that we can measure. And if these are measured, the measurements are associated with a more severe acute postoperative pain, higher postoperative opioid consumption, increased likelihood of chronic post-surgical pain. Then, although these are all characterized as biological, the QST responses, the quantitative sensory testing responses, are also shaped by psychological and possibly social influences, reflecting the term psychophysics rather. Psychological factors influencing chronic post-surgical pain. They have a strong modulatory effect. Do not discount psychological factors. The key contributors to variance in acute and chronic pain outcomes include a negative affect. Patients who are chronically angry are always down in the dumps, have a bad mood overall. Then patients with chronic anxiety and anxiety-related issues. Patients with depression, and this is not just feeling a little bit blue, I mean clinical depression. Pain catastrophizing. Then somatization, where you see physical signs due to psychological effects. Sleep disturbances, this is very important. Where you have poor sleep, pain follows. And then post-trauma or past trauma and past-trauma influences, whether it be in the medical setting or otherwise. When measured prospectively with validated instrument, these factors consistently predict chronic post-surgical pain across surgical cohorts. Their influence remains significant even after accounting for surgical, medical, and other demographic variables. Then also, On the flip side of this, we have resilience and protective factors in the psychological makeup of a patient. Unfortunately, the protective factors have not been researched and studied well. The resilience, however, refers to the ability of a patient to adapt and recover or even grow following challenges or injury. Because surgical recovery involves pain and disability, resilience may be especially important in preventing chronic post-surgical pain. And what we've seen is that most patients just don't develop chronic surgical pain, so which highlights the relevance of resilience in typical recovery. Studying resilience may clarify why some patients recover more easily, quickly, and completely. Then, with the psychological factors, we have an interplay between risk and resilience. And I want to make this clear. The absence of one risk factor, anxiety or depression, does not imply that the patient has a resilience factor. So these are two opposite sides of a coin. The absence of one does not mean the presence of the other. So risk and resilience may operate simultaneously and each contribute uniquely to the patient's outcomes. And then understanding chronic post-surgical pain requires that we must examine both the relative contributions of risk and protective factors. What is the effect of acute pain, and can it be used to predict chronic post-surgical pain? Well, it is strongly correlated, yes. So the more acute pain you have, the higher pain scores you have, there's the greater chance you have of chronic post-surgical pain. But unfortunately, the measurement is not available at the time we need it. We need it preoperatively to see these patients, to identify them, and do something about it. But recent pain scores are available too late for us to prevent any post-surgical pain. So although including acute pain will give you strong correlations, but it may obscure associations with other non-pain related predictors, which are more important. Better preoperative predictors includes pain in the surgical area. So if you have pain in that area already, that's a predictor. Pain in other body regions. So if your patient already has pain in other body regions before the surgery, then the quantitative sensory testing, as I said before, just to get a baseline of pain sensitivity. How does surgery and anesthesia impact on chronic post-surgical pain prevention? Well, first off, the prevention strategies should focus on reducing activation of peripheral and central nociceptive pathways caused by surgical injury. Now, firstly, with surgery, you can make surgery less invasive, which will reduce the risk, but this is not always feasible. The surgical extent is also a poor predictor of chronic post-surgical pain, if you would believe that, and even post-operative opiate use. So the extent of surgery isn't even correlated that well. Periphery targeted strategies to aim to limit nerve sensitization and early nociceptive input. And this can be managed by regional anesthesia, anti-inflammatory and immune modulating medications. Then centrally targeted strategies aim to block central sensitization and to strengthen descending pain inhibition. Psychological and behavioral adaptation. These are all cortical levels to help and them process and how strongly the effect and the autonomic reflexes are activated. Then regional anesthesia is key in preventing most levels of nociceptive pain, whether it be peripheral, central, or even cortical. And then across these studies, interventions show a variable efficacy. So even when applying this to all patients, there is no one silver bullet that will suit everybody. So multimodal is important, and individualized strategies, very important. Now here, just to reiterate what we just said, the levels, we have peripheral tissues where we can modify the surgical approach. Peripheral nerve activation can be mitigated by regional anesthesia, local inflammatory response, and neurogenic inflammation with regional anesthesia and anti-inflammatories. Peripheral sensitization, regional anesthesia again, and then the gabapentinoids. Changes in gene expression at dorsal root level, also regional anesthesia, and NMDA antagonists that can be used. Central sensitization, regional anesthesia again, corticosteroids, MMDA agonists, and alpha-2 adrenergic agonists. Then descending facilitation, anti-inflammatories again, the limbic system and hypothalamus, the psychological, behavioral, and antidepressants. Do not forget about them. Then cortical pain processing is the assessment and pre-screening, and then getting psychological and behavioral interventions there as well. This is a beautiful chart just showing us the timing of these interventions. So we have the timing preoperative, interpost, and recovery times, and then where we should start looking at these risk factors. So biophysical, the surgical approach, the age, sex, centralization of pain, genetic variations, all of that is measured preoperatively. We individualize the risk and do risk stratification. When we get to intraoperative, we have to look at patients' opiate dependence, nociceptive sensitivity, and tendency towards pain that we measured before, so that we can implement the right regional anesthesia, multimodal analgesia, and also minimize opiate-induced hyperalgesia. The psychological factors, anxiety, depression, sleep disturbance, pain catastrophizing, which we identified beforehand, we must also manage and make sure that those areas are also looked at in the acute post-operative period. Then lastly, in the recovery time, we must assess the patient's healthcare access, the coping strategies, and their social support that they have. And these are also part of the risk stratification initially. So here is where these factors play a big role in the recovery period. Now, the assessment and the treatment, obviously, biophysical and sociophysical testing must be done, support, cognitive behavioral support, treatment of these conditions, and being aware of some of them is very important preoperatively. Then, making it practical. Measuring a patient's phenotype for the precision of chronic post-surgical pain prevention is we want to individualize these patients. Precision medicine aims to tailor treatment to each patient's specific pain mechanisms. And the goal is to deliver the right treatment to the right patient at the right dose, at the right time, which will improve outcomes and reduce cost. Achieving this requires high-quality knowledge of your patient's pain phenotype. If you look at all those factors, patients who have psychological factors with biological factors and increased pain sensitivity with poor support. If you look at all those and your patient has none of those factors, it is very likely that your patient will not develop post-surgical pain, chronic post-surgical pain. But the more factors you have in each one of those groups, the higher risk your patient is. So the more interventions would be warranted. So for the same surgery, for instance, mastectomy or breast surgery, one patient may require regional anesthesia plus gabapentinoids plus multimodal other analgesics with psychological support with follow-up. Whereas another patient would be sufficient to just give them a multimodal analgesia and maybe some infiltration of regional anesthesia. And these patients will then both have the same outcomes, but one patient has been identified as high risk and managed correctly. Now, perioperative or preoperative phenotyping assessment will be using brief, validated tools and can provide actionable insights. As I said, there are testing available, short tests that we can do perioperatively. We can send out questionnaires to these patients. They can fill them out online, and we can get an idea of these, and we can do the pain sensitivity testing beforehand. These assessments enable personalized perioperative strategies for preventing chronic post-surgical pain and optimizing recovery. Now, phenotyping for a differential efficacy. This is more research-based because this is a new-ish field. Let's look at this. Some personalized medicine requires evidence base that identifies the interventions that work best for these patients. Now, that's one area that we have to still look at. More research is needed on how traditional and non-traditional chronic post-surgical pain prevention strategies will perform across the different risk and resilience phenotypes. Establishing these approaches with regional anesthesia, analgesic adjuncts, we need a more strategic testing to help phenotype stratification. Now, this will initially be more labor intensive if you want to implement this. But again, in future trials, we might include moderation analysis to determine which subgroups derive the most benefit from specific interventions. That would mean that it is not a shotgun approach, but that we have specific interventions for specific subgroups of patients, rather than a one-size-fits-all. Shoot them with the most analgesia that we can do and manage all these patients as though they will develop chronic pain, because they don't. Most of them do not. Some therapies, as I said, will help only a subset of patients, but with large effects in that subgroup, and then discarding them from risks us losing out on valuable tools. RCTs should incorporate phenotype assessment to reveal differential efficacy, and this will guide us in the prevention. And then trials can be enriched with patients showing specific traits. If you have identified these anxiety or catastrophizing, and we have certain interventions, then we can see how this impacts the pain. And then understanding phenotypic responders supports the rational use of resources, as I said. So treating the pain before it's there, rather than trying to pick up the pieces once it's broken. Thank you very much. I hope that you learned something here. As I said, I am by no means an expert on this, but I find it wonderfully refreshing, and I think it is a new look on managing patients with post-surgical pain. Thank you for your attention.